a not so common scenario where, in spite of our best reasons and intentions, we'll end up in situation where our nicely done surgeries fail. So I come from India. Uh, to be precise, I come from the very center of India. We have got a geometrical, I mean, the 0 mile in India. This is Nagpur, where I am an associate professor in a university here, along with my own private practice. So, as Professor Altani has rightly pointed out, the right patient and the right surgery is mandatory for your selection in a 4-part and a given situation. And patient factors, they matter a lot whenever you are doing a proximal humerus. But in spite of all these intentions, sometimes the osteosynthesis and orthoplasty doesn't go the way we have planned it. But I would like to say that not all failures are created equal. When I say this, what I mean is that there are failures which were avoidable, and there are circumstances which were unavoidable. So in spite of a nicely done surgery, if the patient factors don't allow and your osteosynthesis fails, that is under some of the unavoidable circumstances or complex scenarios. So we have to have some strategies for learning from these failures, and need to ask the pertinent questions as why and how this particular implant or processes have failed. And we need to base our strategies and learning from these cases, and develop a basic tenet as to manage the patient and give whatever is the best for the patient. And therefore we can make some sense or some order of this chaotic situation of a failed primary surgery or a failed primary osteosynthesis. So as I said, the primary tenet is that primarily we have to balance or make a balance between the patient expectations and available resources. Now, available resources, because I come from India, we are a developing nation of 1 billion, 1.2 billion people. We have scarcity of resources, so we have to give or deliver the best possible scenario, best possible case scenario in a failed implant to a patient who cannot afford even a single surgery. So we have to understand the spectrum or reason for failure. So whether it is the implant which has only failed, which is slightly a easier scenario to deal with if there is no side by infection, or the patient factors are pretty reasonable and they are on your side, or is there a triology where the implant has failed with an infection with a comorbidity of patient factors. So I'm going to present 3 different cases where we are going to see each scenario of failure, like whether the implant has only failed, whether there is an implant with infection, and whether the patient factors are involved. So what are the options once we come across these situations? So we have got huge amount of literature talking about revision osteosynthesis, orthoplasty, single stage revision of orthoplasty, 2-stage revision of orthoplasty, use of Prostalac fusion and excision orthoplasty. So we are going to consider 3 different scenarios, and let us see whether we have done justice in our cases. So this is case 1. This is 11 months old proximal humerus fracture. He was nicely fixed in the initial surgery, but sustained another fall. So this was unavoidable complex scenario, as we have seen. So the case of a broken implant. So it was a pretty straightforward, a day-to-day occurrence in a setup which we work. We have to remove the implant. Go ahead. It was an implant failure without any infection, and the patient was fairly young. So we went ahead, put a bone graft, did a revision surgery, put the black in on osteosynthesis, and it is a pleasurable day in the OR when you able to see after this, when you are able to see this at the end of a surgery in this particular fracture. So the patient went on and healed well. So this is a case scenario where only of the situation with proper planning, with a bone graft and a revision osteosynthesis. A case 2, a slightly complex scenario where we have a 52-year gentleman operated 2 years back for a proximal humerus. He's a tailor by occupation, and as Dr. Altani has pointed out, that the posterior circumflex, if it is compromised, is result into AVN. So he had AVN with screws protruding inside the shoulder and painful range of movement in all activities of daily living. So we went ahead, and in this particular case, there was no issue of affordability. He was able to afford a revision surgery and expensive prosthesis. So we were able to put a reverse. So we had a satisfactory outcome in this particular case. Now, let us increase slightly complexity and add the other 2 factors of infection and patient morbidity. So a 54-year-old gentleman operated for a proximal humerus fracture, presented with a discharging sinus for 3 months with implant in situ. So what do we do? What do we do in this case? So the available options were, and he was a farmer by occupation, a laborer who can't afford a revision surgery or revision multiple surgeries. So here, everything was done right. Still, in spite of that, infection and an implant failure. This was his pre-operative passive range of movement. Flexion was limited to 45 degrees, extension to 10 degrees. He couldn't do his activities of daily living. So we thought we were smart. We would put a stage 1 cement spacer with a mold, but it is not available in India, and there are serious cost issues. So there is a facility of a 3D printing. We got a CT scan of the opposite shoulder. We molded it with the help of our dental guys, and we created a mold which was indigenous. And then we implanted the Prostelac based on a tense nail. And these are his immediate post-operative passive range of movement. Flexion was 0 to 150 degrees. Extension was 0 to 50 degrees. External rotation was up to 90 degrees. And this is his post 2 years follow-up. Now, we have taken a proper consent of revision or revising it to a stabler implant, but the patient doesn't want removal of his Prostelac. He's back to his all farming activities. He is using the trick movement of his scapula for doing his activities, but he is happy. Now, why Prostelac? Why Prostelac? This is a very widely published study and usage of Prostelac, antibiotic protein acrylic cement for the treatment of infection of shoulder arthroplasty by John J.P. Warner from the Boston group. And they are saying that Prostelac works because it maintains the appropriate periarticular soft tissue tension, preventing capsular and ligamentous contracture, also eliciting high local concentration of antibiotics. At the same time, there have been some reports of osteolysis, but it works in scenario shoulder being a non-weight bearing joint. It can definitely help with continuation or retention of this Prostelac. So these are the indigenous mold created by that group, and they are good for 2-stage revision surgeries in case they experience infection after the primary orthoplasty. But we were able to extend or extrapolate this use in a failed osteosynthesis. So this is a case 3 where everything was done right. According to the surgeon, it failed. The primary surgery failed. He went ahead and he did a revision with a hemiorthoplasty device, which also failed, and the patient came with pain and infection, and there was a discharging sinus. So another farmer by occupation, a lady, a frail old lady, implants not available. So we went ahead and did the excision orthoplasty. And this is her 6 months results. And this is the 18 months follow-up. So she is at least able to carry out her activities of daily living and able to do her work with the available resources which she had at her disposal. She's able to continue her life, day-to-day activities. So take-home message, we need to understand, in the case of a failed osteosynthesis, what is the bacteria, the patient, the type of infection, local soft tissue, and most importantly, the surgeon and the resources which are available to us, and deliver what is the best possible thing for that patient. So take home message, we need to get it right the first time. We need to learn from our failure. Prostelac is a viable option in shoulder in a cost constrained scenario, and excision orthoplasty serves well in well indicated patients. Thank you.